Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitians. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes.
Welcome to another episode of Food Freedom and Fertility. I am your host, Caitlin Johnson, and I am solo recording this episode today. I don't know that we have done this in the 5 years of releasing Food Freedom Fertility podcasts, but I'm excited because this is just me and you. The only thing in between us is a microphone and whatever you're playing this on, and I'm going to break down for you today the medications that you will typically first be offered when you are diagnosed with PCOS and trying to conceive. So whether you have a PCOS diagnosis from a long time ago and now you're trying to conceive, or you just found out that you have PCOS and you're trying to grow your family right now, these are typically the medications that are going to be offered to you. So we're going to kind of do this in a stepwise order of what medications will typically be recommended first. And as we kind of go through it, I want to talk with you about how the medication works and why it might impact PCOS and ovulation and fertility, what the benefits are, what the typical dosage is, how it's used, and maybe what the side effects or symptoms or drawbacks of these medications might be. So buckle up. It's going to be a fun-filled time together. I'm going to throw a lot of information at you. I'm going to kind of break it apart bit by bit so that it's easily digested and something that you can take on. So welcome to another episode. Let's get started. So the first medication that you're typically offered with PCOS is something called metformin. And this is a drug that's used in what we would call off-label. It is made for something else. It is not like FDA approved for treatment of this particular condition. And so we call it off-label. It's used in an off-label manner to what it was originally designed for. That doesn't mean it's not effective. It doesn't mean that it's not helpful. It just is something called off-label. So I want you to know that going into it. If you're like, hey, I thought this was like a diabetes medication, that's why, but it's still very effective in treating PCOS. So how metformin works, and it's also called glucophage. You might see metformin ER, which means extended release, or glucophage extended release. It works by improving insulin sensitivity. It does it by a handful of ways. It slows down how fast your liver gets rid of glucose when you have low blood sugar. It helps impact the cells themselves, kind of turning on their receptors for insulin. And because there's kind of a cascade with PCOS where you have insulin and it's doing its job of trying to get blood sugar into the cell. So it's inside the cell sugar and not blood sugar anymore. Um, our ovaries have lots of sensors for this. And in the sensors of our ovaries, we can be very effective at talking to the insulin while the rest of our body isn't. And so when metformin enters the scene, it can lower how much insulin's around, which trickles down to less insulin touching your ovary. When there's less insulin touching your ovary, we have a scenario where your ovary can make less androgens. So it decreases the amount of testosterone, it decreases the amount of DHEAS that your ovary produces. By doing this, it can actually improve ovulation. So that's why it's typically kind of like a first line medicine. It is generally considered safe because it's been around for a very long time and is fairly effective under certain circumstances. So, a typical dosage, how your doctor may start out prescribing this medication for you, is 500 milligrams per day. Typically, the goal is to titrate you up to 1,500 milligrams per day. So that 500 milligram day dose would go up to 1,000 and then up to 1,500. One frustrating thing that I see very often is that doctors don't explain this very well, or just start people at 500 milligrams thinking this actually isn't for diabetes. And so we're not going to titrate up to this higher dose.
Hey, Food Freedom and Fertility family, it's Sophia introducing Fertility Cloud. High treatment costs can be daunting, but here's some good news. 80% of Fertility Cloud patients have gotten pregnant for under $2,000 after just 5 months of treatment. Starting your family doesn't need to come with a huge price tag. Fertility Cloud virtual consultations mean you can talk to them from the comfort of your couch. They create personalized plans for men and women, whether it's ovarian stimulation with Clomid or Letrozole, Ovidrel trigger shots, guidance on male fertility, or even weight management support with medication. As a special for Food Freedom and Fertility listeners, get $50 off your initial medical doctor consultation. With meds delivered in just a day or two, unlimited support for your questions, and free follow ups when needed, they're here to make your path to parenthood smoother and more affordable. Ready to start? Visit myfertilitycloud.com and enter Food Freedom, one word, at checkout.
This is frustrating because it's typically not very effective at 500 milligrams per day. I see this starting to work closer to 1,500 milligrams per day. For some clients, it needs to be higher to like 2,000 milligrams per day. The reason why they start you low with this medication and titrate you up is because it can come with a lot of side effects. Typically, they're hard on your tummy, can make you feel nauseous, can also give you diarrhea. And because of this, we kind of start low and then we increase over time. It is a first line use for insulin resistance. It can improve ovulation, but it can also improve other insulin resistance related side effects of PCOS, things like resistance to weight loss, gaining weight. It can also impact energy levels. And because it impacts the ovary and lowers testosterone, it can also impact other androgenic symptoms like hair loss or hirsutism. But I would say it's kind of more of a muted effect on those. But in terms of fertility, we're often seeing this and using it because it is effective at helping to trigger natural ovulation. It also has been shown to lower miscarriage risk in insulin resistant patients. And so it's generally kind of a first step, even before somebody might consider giving you ovulation stimulation medications. Even though this can help trigger natural ovulation, I wouldn't put this in the category of ovulation stimulation. Those we'll talk about in a little bit. That's more like the letrozole or Clomid type options. The drawbacks of metformin are generally the side effects. Some people just never get used to them: nausea, diarrhea, bloating. It can have an appetite suppressing effect for a lot of people. That's as much of a benefit as it is as a drawback, maybe, because feeling like you have uncontrollable appetite with PCOS is something that people report fairly often. Holistic alternatives to metformin are things like inositol, chromium, berberine, cinnamon. There's actually a handful of them, N-acetylcysteine. I really like to use inositol either in combination with metformin or instead of metformin. I especially like it because I continue patients on in pregnancy in it. And so it's always nice if you can put a support in that can help ovulation and help egg quality, that you then don't need to abruptly stop as soon as we see a positive pregnancy test. One of the nutritional considerations with metformin is vitamin B12 deficiency. And this is particularly important when we're talking about getting pregnant because B12, folate, choline, handful of other vitamins are really important early on in development, especially of babies' brain and spinal cord and nervous system. And so we don't want to go into pregnancy deficient. If you're coming off of hormonal contraceptives like birth control and you're on metformin, that's like a double whammy hit on vitamin B12. B12 is something that you get from animal products. So if you are somebody that is vegetarian or vegan or in some sort of category of those, this is even more important if you're on metformin for us to consider. Metformin is not something that I turn to as a first option, even though doctors do, because I think inositol is easier on the stomach and performs just as well in research. And we can oftentimes layer in something like inositol, berberine, chromium, cinnamon, and see lots of benefits with kind of this holistic management. If you have insurance, though, and cost is something that is really important to you, metformin's often covered by insurance. And so if your tummy can handle it, it's not necessarily a bad choice. Oftentimes, practitioners like your OBGYN or your midwife will choose to keep you on metformin through fertility treatments and on into pregnancy, because those of us with PCOS have a higher risk of developing gestational diabetes. So that's metformin. It is often recommended in unison with other fertility treatments. So, like metformin plus Clomid or metformin plus letrozole. We have a lot of research on these things, and what we see, the benefits of metformin in terms of lowering insulin resistance has a widespread physiologic and metabolic impact, not just at the ovary level. And so, even if it isn't something that stimulates ovulation for you, if you're not the person that being on it 3 or 6 months stimulates ovulation, you may need another layer of medicine if medicine is the route that you want to go. Um, but that doesn't mean that it's not helpful to keep on as you consider something like letrozole or Clomid. So that's metformin. I'm going to talk about these kind of in the order of your likelihood of getting prescribed them. I'm skipping over hormonal birth control because you don't take birth control to get pregnant, but I will say this. Hormonal contraceptives like birth control are often used in fertility treatments to do something that doctors will call quieting your ovaries in between something like moving from IUI to IVF, because they want to kind of shut down the work of the ovaries. I find this even more often in my PCOS patients than other patients because we have this history of polycystic ovaries and a handful of follicles that are just cooking and stuck in this maturing process, and they're releasing a lot of hormones and can kind of jumble up the messaging systems. And so doctors really like to do a couple cycles even of quieting the ovaries in order to essentially almost like clear those immature follicles that are just stuck in there. Okay, so that's all I'm going to say about hormonal contraceptives in the context of this episode. We're going to move on to progesterone. Oftentimes, progesterone is prescribed like a medroxyprogesterone, sometimes even a bioidentical progesterone, depending on who you are seeing as your provider. Midwives and more holistic providers might look for more of a bioidentical option. Kind of your mainstream OBGYN or fertility doctor or reproductive endocrinology doctor will sometimes go to these more progesterone-like options. So how this works is it mimics natural progesterone in the body. Why it's often offered to people with PCOS is similar to kind of the hormonal contraceptive. It's not necessarily to quiet the ovaries, it's to tell the uterus, hey, we ovulated. So thicken that lining and get ready for baby. And then what you do is you stop taking the progesterone. We're again mimicking the natural cycle that you would have, where if you aren't pregnant, you stop taking progesterone and then your body sheds your uterine lining. This is very common in fertility treatments. It's also very common in doing fertility workups because a lot of times doctors want to do tests like ultrasounds at a certain point in your cycle. It's also very common because when we start something that we're going to talk about next, like Clomid or letrozole, you want to do that on specific days of your cycle. If you haven't had a period in a year or in 3 months or even a month and a half, we're not coming in with a fresh, clean lining. We have no idea if you already are starting to develop a follicle that could become a dominant follicle and ovulate. And so we start throwing medications at you that impact hormones. And then that kind of muddies the water when we're talking about kind of starting fresh and trying to take a little baby egg and get it ready to be the dominant follicle. We're picking up midstream and we don't know how long that egg slash follicle has been there. We don't know how much exposure oxidation wise it's been exposed to. There's a lot of reasons why it's kind of nice to start with a fresh cycle. I will also say to prevent cancer risk or lower cancer risk, we do want to bleed 3 to 4 times a year. So if you're somebody who's like, hey, I don't get my period, it's not a big deal, and you're in between trying to get pregnant or something, it is a big deal that we get you to bleed. Your body was meant to bleed. Your body was meant to be exposed to progesterone. And if you're not ovulating and making your own progesterone, we want you to. And it's important for you to, if we can't get you ovulating, we want to take a progesterone so that we can stimulate a bleed to lower those risks. Okay, so progesterone mimics natural progesterone. You make progesterone after you ovulate, and it gets ready for gestation, pregnancy. And if your body doesn't get the signal that you're pregnant, your ovary stops making it in a little, even smaller organ within the ovary that's temporary called the corpus luteum. The corpus luteum stops making progesterone, it signals a bleed of the uterus. And that's what we're trying to get happen. That's how it works. We take it for a period of time and then we stop taking it. If you go on progesterone, you're just taking it forever, you're doing it wrong, girl. Okay. So the dosage is typically 5 to 10 milligrams per day if you're taking like a medroxyprogesterone, and you take that for 5 to 10 days and then you stop and we expect your cycle to show up. If we want it for a different reason, for what we would call luteal phase support, where we've gotten you to ovulate or we've triggered ovulation with some sort of medication and we can confirm ovulations happened, then you might take something like a bioidentical progesterone, 100 to 200 milligrams, either orally or vaginally, or depending on your fertility treatment, sometimes you can even take it as a shot. It's used to kickstart a cycle. It's used in short luteal phases, when we see issues with thin lining and after ovulation to support the chance of pregnancy. The drawbacks of being on progesterone are that you can feel drowsy, you might feel a little bit more moody. If you keep taking it and don't stop it, it will delay your period onset and give you false hope of pregnancy potentially. And it can cause, for some people with the suppository option, vaginal irritation. I had a client who has a long list of allergies, including egg and soy and peanuts and a handful of other things. And she was doing IVF, and she, in a historical IVF that yielded her son, she had had a really terrible reaction to the vaginal suppositories. And she was going through another set of IVF transfers. And I was working with her at this point, and I was like, go in and talk to your doctor about what's in the suppositories. And we found out that there was peanut in it, like peanut oil or something was in one of the ingredients. And so the support that they had given her to hopefully help her ended up being very, very, very uncomfortable for her. And so if you're using a suppository and you have a list of allergies, make sure you talk to your doctor or your pharmacy, your pharmacist specifically, about what's in it to make sure that we're not giving you something that you're allergic to. Okay. What I think that you can do to help improve progesterone production. The first thing is getting you ovulating. We won't make progesterone if we're not ovulating, and we have to do that in a handful of ways with PCOS. Oftentimes, we're talking about improving insulin resistance, and we do that with more than just metformin: diet, exercise, sleep, stress support. Again, things like myo-inositol, cinnamon, um, going for walks after eating, magnesium. When we're talking about supporting progesterone and we're not actually talking about getting you ovulating. We're just talking about like, hey, I am ovulating, but I have a short luteal phase. I always want to think about stress reduction and sleep support. I also want to think about vitamin B6, magnesium, cholesterol rich foods. So when you're thinking about foods and supporting progesterone, I want you to think about green leafy vegetables, orange and yellow fruits and vegetables, squashes, pumpkins, citrus vegetables, bananas. And then I also want you to think about cholesterol rich foods like the yolk of an egg, for instance. So these are um, kind of the holistic ways to support progesterone. I find progesterone support after confirmed ovulation has very little drawback in the PCOS community because we are at higher risk of miscarriage, and this can lower the risk of miscarriage. And egg quality is a thing in PCOS for a handful of reasons. And if we can do something to support the chance of pregnancy after maybe a tired corpus luteum is hanging out trying to do all the work of progesterone production, I say why not? Why not? So, this is often something that you need to advocate for. You can ask your doctor, hey, let's check my progesterone levels after we confirm ovulation 7 days later. That would be called a 21-day progesterone. You could ask for that, but tell them I'm going to go 7 days after I confirm ovulation. You could fast track that and just say, hey, I know it's really common in PCOS to have low progesterone, and I really want you to provide me with some progesterone support. If your doctor is like super anti that, let's have a full conversation about it. And if they're still really anti that, then maybe it's worth looking into a provider that could come in alongside of your doctor, maybe a naturopathic doctor, maybe getting in touch with My Fertility Cloud and having a conversation with one of their fertility doctors about with them about your concerns and seeing what they may have to offer for you. Hey, friends, we're taking a break from this episode so I can share with you a little more about one of our sponsors, Fullwell. Fullwell's a reproductive health company offering superior nutritional supplements that are made without compromise to support women and men throughout their reproductive journey. I have taken Fullwell's prenatals, their fish oil, and have literally tried every product they've released, and I stand behind this recommendation with my whole heart. One of my favorite things to recommend to clients is their fertility trio. This includes their egg and sperm quality supplement, their women's prenatal, and fish oil. This helps proactively support you getting ready to conceive. This trio includes things like CoQ10, ashwagandha, and NAC. It makes me think of a life vest. You don't want to go into pregnancy without these foundational supports. And if you've been struggling while trying to conceive, this is the time to upgrade your prenatal fertility game and check out Fullwell. Use code FFF20 today to get 20% off your first order. Okay, so now we're moving into the actual ovulation stimulation medications. And these are the first things your doctors will think about when it's time to bring in some of the heavier hitters. In the past, your doctors would have thought of Clomid first. Now, letrozole is kind of gaining favor. I think as soon as we see the baby boomer physicians kind of rotate out of active medical management, we're going to see letrozole really take the stage. I would say if you are trying to get pregnant now and your doctor is your parents' age or older, they might go to Clomid first. And that's not wrong. It's just that research is continuing, and letrozole has a few risk advantages, I would say, and sometimes a little bit less of side effects. So we're going to talk about it ahead of Clomid, but I want you to hear me. I've seen a lot of clients get great effect from both letrozole and Clomid. So if you're moving on to medication management of your PCOS and ovulation induction, it's okay if your doctor wants to do that instead of this one first. Oftentimes they're using the one that they're more comfortable with and have seen work and know the dosages better and just have clinical experience with. and that is worth something. So don't completely discount it if they start with Clomid. We're going to talk about letrozole first, though. Letrozole and Clomid both work in similar ways in that they help your body make more estrogen. Now, your ovaries are responsible for making most of the estrogen in your body. And in a PCOS ovary, sometimes we don't do a very good job of turning testosterone into estrogen. Sometimes we just don't make enough estrogen for this kind of peak that happens right before ovulation. Your estrogen goes up, then your LH goes up, and then you ovulate. LH doesn't go up without estrogen not going up. So the point of both letrozole and Clomid, even though they work a little bit differently, is to get your estrogen to go up, okay? Letrozole, or the generic is Femara. It temporarily lowers estrogen's receptors, essentially. Like it tells the brain there isn't enough estrogen. It's kind of blocking the estrogen receptors. And so it tells the brain, hey, you need to make more follicle stimulating hormone. This will tell the ovaries, make more ready to go follicles, stimulate them, make them mature. Okay. In PCOS, our ovaries are a little bit resistant to this FSH message, and we often have more LH working at our ovaries. And so this is oftentimes very helpful. It's helpful at maturing the eggs and getting them ready for ovulation. A typical dosage is 2.5 milligrams per day, and it's given on your cycle day 3 through cycle day 7 or cycle day 5 through cycle day 9. If you do this 2.5 milligrams per day dose and it doesn't work, doctors will typically the next cycle try 5 milligrams. And if that doesn't work, then they will try 7.5 milligrams. A minimum effective dose is 2.5 milligrams typically, but I've seen a lot of patients need to kind of climb that scale before we see it actually induce ovulation. It's used in conjunction with metformin very often, and it can be used also along with trigger shots. We see letrozole used first to try and stimulate ovulation when we know that tubes are open and patent, and we know there's not an issue in a semen analysis. If there is issues there, you might be offered letrozole in kind of a combination with other treatments. If semen isn't optimal, you might be offered letrozole in an IUI environment. If you have an issue with your tubes, you might be offered this in a scenario where we're working with IVF, either to get ready for transfer, like in a modified natural cycle, or depending on what your IVF stimulation is to try and get a handful of follicles for retrieval. Doctors use this in different ways. So it's a first line ovulation induction in PCOS. Sometimes your OB will offer this to you and you don't even need to go see a reproductive doctor. If they're doing that, they may not have done something called HSG, where they go in and put a dye into your uterus and see if your tubes are actually open. That can be really helpful before you start this medicine so you don't spend 3 or 6 months taking this medicine and then come to find out that you have blocked tubes. Okay, so if I was going to take letrozole, I would first consider having that procedure done. It's called an HSG. The benefits of letrozole is it typically improves ovulation rates. It improves pregnancy rates. It can help thicken uterine lining so that you are kind of ready and optimal for implantation. It does come with side effects. The side effects are typically things like hot flashes, dizziness, fatigue, and headaches. Headaches, I would say, is the most common one that I hear clients discuss. When we are thinking about letrozole, I want you to already be thinking about things like myo-inositol. I want you to already be thinking about things like fish oil. You may want to consider in kind of moving on to this ovulation induction period of time, adding in something like a baby aspirin along with that just helps thin the blood a little bit around the ovaries and allow nutrient delivery. It also can help with placental development really early on and lower the risk of things like um, preeclampsia. So I like to think about those things when I'm working with clients and kind of setting them up for best case scenarios. We also want to be thinking about anti-inflammatory eating. And I always like to think about, are my bowels moving well before I start taking these? Because we're going to make a lot more estrogen and we get rid of estrogen in our stool. And so do we need to do anything like magnesium or fiber support, walks, anything like that to help get you ready for taking this medication and having the best chance of success? Okay, so it's kind of partner in crime, and the one that was popular long before letrozole was popular is Clomid. It's also called clomiphene citrate. It works by increasing FSH as well and stimulating ovulation. Okay. Its typical dosage is much higher though, 50 milligrams per day for 5 days. Again, typically cycle day 3 through 7 or cycle day 5 through 9. And if that 50 milligram dosage doesn't work, we then see similar treatment. We increase to 100. That doesn't work. We increase to 150. Oftentimes, and maybe even more often than letrozole, it's combined with metformin because we actually have a handful of studies that show this combination is very successful with PCOS. If letrozole fails or isn't tolerated, sometimes doctors will move on to this, even though letrozole has kind of grown in favor and has become kind of the first option that doctors consider. It's kind of widely accessible. It's been used for a long time. It does have a history of helping ovulation in women. Some of the downsides or side effects of this that are not as common with its counterpart, letrozole, is that it can kind of thin the uterine lining, can also thin or decrease cervical mucus. And because it can do that, it can impact in trying to get pregnant at home, having success with intercourse. If we don't have really good cervical mucus, sometimes sperm have a little bit of a harder time getting through the cervix, up through the uterus, and towards the fallopian tubes to be ready for egg. Its side effects are things like mood swings and irritability, hot flashes. It I'd say one of the main reasons doctors prefer to use letrozole over Clomid now is that we know that there's a little bit of a higher risk of twin or multiple pregnancies when compared to letrozole. I like to think about holistic support here, minimizing those side effects. So, again, are you stooling regularly? Are you walking? Are you hydrated? I like to add in some cervical mucus support. So, things like evening primrose oil, again, staying hydrated, magnesium, a really good hydration support, which could just be like some citrus squeezed in water with a little bit of salt and a little cream of tartar for some potassium support. Beet juice are also great. Arginine is also great. So I like to think about those with letrozole and Clomid. Now, when we start moving on past letrozole and Clomid, you're typically working with a reproductive endocrinologist or some type of specialized fertility doctor. When we start talking about gonadotropins, we're talking about FSH or LH injections. So these are things that your brain makes to tell your ovary to stimulate. They work by kind of bypassing that brain and directly stimulating the ovaries to grow follicles. The typical dosage is between 75 and 150 international units a day, and it's adjusted based on how your body responds. They're usually used after Clomid or letrozole cycles have failed. More often, they're used in something a little bit more medicalized with like a lot more scans, and we're watching and we're looking to see, is there a dominant follicle? Oh my gosh, are there so many? It's used in conjunction with IUI and IVF. And it's used very often with women with irregular cycles, absent ovulation, or kind of failed attempts with letrozole or Clomid. They're very powerful at stimulating ovulation. They're expensive. They're intense. They are shots. There are high risks of multiple pregnancies. You can have ovarian hyperstimulation syndrome where you have so many follicles. Those follicles become the biggest cell in your body when they're getting ready to ovulate. So let's say you have 20 of those, you are making that ovary kind of hang. And there's a lot of risk there. Okay. It can torque and kind of spin. Um, it can be life endangering. So these are not things to um, consider lightly. It's not that you can't use them or that you shouldn't use them. I'm just saying they shouldn't just be like, oh, IUI didn't work or oh, letrozole didn't work. Let's move on to this next step. Especially if you haven't worked with somebody like Sophia or I or a naturopath who can like help with the supports alongside and help make sure you're giving that egg and you're giving your sperm the best option and the best chances at success. We are going to take a break from this episode and chat a little bit about one of our sponsors. Truth be told, when we were contacted by Fond to see if they could sponsor our Food Freedom Fertility podcast, it kind of was like one of those dream come true sponsorships. Let me explain why. There are very few foundational foods that cover broad nutrient needs for fertility, gut health, and baby's brain development like Fond is. And not only do they create these foundational foods, they kind of exceed in every category that I can think of what we want to put into our bodies. They're the only verified regenerative through land to market bone broth, tallow, and lard on the market. Unparalleled animal sourcing, all pasture raised, or 100% grass fed and finished cattle. All the herbs and vegetables that are in the blends and the seasonings of these broths and lard are exclusively organic. Nothing is packaged in plastic. The entire packaging process is plastic free from kitchen to their shipping materials. When I think about this regenerative fat line that they've just introduced to the market, I use it in so many different ways. I've used their pork lard that's flavored with cinnamon and vanilla when I've been sauteing apples to put in my children's oatmeal. I've used their regenerative beef tallow that's flavored with chili and garlic as I've sauteed meat that's going to go into a slow cooked pho style dish. And then I've used their broth within that dish itself. I love the flavor combinations. I love that I can trust that these foods that I'm putting in my body are so clean but truly delicious. The infused flavors are ready to sip, and all the Fond flavors can be used to take any dish from good to gourmet. I've been using these for the last 4 or 5 months every single day and have seen a huge difference in my own health. And I know this is our fertility podcast, but we started taking on Fond as a sponsor at the same exact time that my dad got diagnosed with esophageal cancer. And I had so much peace in these moments where he could hardly eat anything that he was sipping on a bone broth that had so much gelatin and collagen and amino acids that I knew we were reducing inflammation in his body and giving him just these beautiful, naturally occurring electrolytes and protein that was so easy to get down. This is one of my most favorite products I've ever used in my kitchen. And I am so proud that we get to partner with Fond. Fond has generously given us a coupon code for their website where you can receive 10% off. So that's FFF10. Or if you click on the link in our show notes, it actually brings you to a landing page where the discount is baked right in, and some of Sophia's and my favorite products are hanging out on that page for you to peruse. Please give this brand a try. please support them. If you haven't listened to our episode, you are just gonna scream at how incredible this brand is and what they've come through, supporting a woman-founded business that has your health and our planet's best interest at heart. It's something that I can't be more proud that we get to partner with, and they sponsor you getting this free fertility information straight to your phone every single week. Now back to our episode. There are side effects to these. They include things like abdominal bleeding and breast tenderness, certainly highs and lows when we're talking about hormone shifts and emotions. When we start talking about these types of injections, we're talking about sudden weight gain, severe bloating, and nausea. I like to do things like castor oil packs with my patients, hydration, dry brushing, um, a lot of mindfulness support, yoga, deep breathing, definitely walking. This is a time where you don't want to do a lot of heavy lifting and running and jumping because of that risk of ovarian hyperstimulation. Ovulation trigger shots are typically HCG injections. So we are using a hormone that your body makes actually after it sees pregnancy. Okay. It mimics an LH surge, which helps to trigger that final kind of egg maturing and then ovulation within 24 to 36 hours after injection. This is typically given in something called Ovidril. That is a 250 microgram. Typically, we're talking HSG dosages of like 5,000 to 10,000 IUs. It can be used at home with timed intercourse. It can be used with IUI. It can be used with IVF cycles. It can be used after we confirm a mature follicle with ultrasound imaging. It helps you predict ovulation a little bit better in timing intercourse. But even if you're doing these HCG shots, if you're taking letrozole or you're taking Clomid, and we're seeing follicles growing on your serial ultrasounds, that just means you're taking them day after day. You don't want to hold off on having sex until you do this ovulation trigger. Okay. So we want to consider this helpful at timing intercourse. Definitely, but we don't want to use this as we only have intercourse after we've had this injection, because you're missing out on valuable days that you could have intercourse that could still yield pregnancy, because we know that sperm can live up to 5 or 6 days in quality cervical mucus. Um, and so don't use these shots like Ovidril and miss out. Now, if you're doing something like IVF, you don't want to take Ovidril and be having lots of sex, because you may release a handful of eggs and like the risk of multiple pregnancies is so high. Don't do that. Abdominal cramping, breast tenderness, ovarian hyperstimulation. Um, I'd say the other drawback of this particular injection is not understanding false positives on home pregnancy tests. So if you take a shot that has HCG in it, you want to wait at least 10 days after that shot to start testing for pregnancy. Ideally, I would just wait 14, okay? Because we want to make sure your body clears this pregnancy hormone that we've just put into you before we start testing to see if your body's making pregnancy hormone on its own because you're actually pregnant. These are the main medications your doctor will think about prescribing for you to help your PCOS infertility. Here are some common questions that come up from patients of mine or people in my courses, even just on Instagram, that come up surrounding these medications, that come up um, because everybody's different, your cycle's different, and your experiences are different. What you're being told by your doctors and how these are working and how to use them can be different than even what you just heard me say. So these are some common questions that come up for me. Patients often ask, what if I am ovulating? Why are they offering me letrozole or Clomid if I know that I'm already ovulating? And there's a couple reasons for this. The first is sometimes you are ovulating Yes. But you ovulate on like day 45 or you ovulate on day 60. And so you have in a 60 or 75-day period in both of those examples, one opportunity to get pregnant. So if you start taking letrozole or Clomid and we offer you this medication that can shorten your cycle to like 30 days with a chance of ovulation in that, then over that 60 or 75-day cycle, we've given you two and a half opportunities at trying to get pregnant. So sometimes it's just a game of numbers. We need to give you more cycles with timed intercourse and opportunities for you to get pregnant. Another reason why doctors may consider one of these medications, metformin on its own, or even letrozole or Clomid as first attempts, is because we want to improve egg quality. And because the PCOS ovary struggles with insulin resistance, it has some physiological and metabolic differences in it than other ovaries. We turn certain chemicals from this chemical to that chemical way too easily, like myo-inositol to dechiroinositol, or um, not turning certain molecules like a hormone, testosterone, into estrogen well enough that we have imbalances there. We don't have enough melatonin there. So antioxidant support becomes really important. N-acetylcysteine, another powerful antioxidant, can be helpful for egg quality. But these medications that help increase estrogen help increase FSH signaling to the ovary, help in all these ways, may help improve the quality of the follicle that gets ovulated. And so it's giving you a better chance at pregnancy, even though you might be ovulating on your own. We're kind of amplifying certain signals so that you have a better chance of getting pregnant. Now, if you have not timed intercourse well and you are not ovulating and your doctor's like, hey, let's speed track past letrozole and Clomid and just go straight to IUI, I would ask them questions. That would raise red flags for me. Have you done a semen analysis? Is that why you're going to IUI? Because the sperm are not in enough quantity, or there's something going on with how they move, their motility, or how they look, their morphology. And so they're not moving to the egg. Or maybe even getting through the cervix. Did they find some issue with your cervix that there's scarring from STDs or a colposcopy or something like that? And so sperm may be having a hard time getting through. Is there something physiologic going on that's making us skip timed intercourse? Another physiological sign like that would be blocked follicle or blocked fallopian tubes. So those are questions that I would be asking back. That would be a red flag if we've skipped over letrozole and Clomid and are going straight to letrozole and Clomid paired with IUI minus a reason. Another reason a doctor might consider that is age. Only you can decide how sensitive you are to that, because that is a risk factor of fertility that is unmodifiable. We cannot go back in time. We can't start trying to conceive at 32 instead of 37 or at 26 instead of 35. And so if your doctor is kind of showing a clock in front of you and we need to be more aggressive, I still might consider that an orange flag and say, why, what options, like what are the alternatives to what you're offering right now? Another reason why you might be offered letrozole or Clomid is because you're just not ovulating at all. That's it. It's an ovulation stimulation medication. If you are listening to this and you are not having a period, you may be offered these medications. No period means no ovulation. We need you to ovulate to have any chance at timed intercourse at home. Okay, so that is very, very important. If you're listening to this and you're like, I don't think I have PCOS, I think I might fall on the other end of anovulation spectrum, where it might be something like hypothalamic amenorrhea, where I'm not eating enough for the activity I'm asking my body for, or eating disorder history or something like that, then nutrition is more important than letrozole or Clomid. I would argue nutrition is more important than these medications in every category, because in any category that we're trying to get you pregnant, we still have to have good egg quality, good sperm quality, and a healthy body to grow that baby in. Nutrition is foundational for it all. It's also foundational for you to be around for years and years and years and years and years as a healthy parent to take care of this beautiful family that you're growing. So, nutrition is more important than ovulation stimulation, IUI, or IVF when you are not ovulating, period. But especially if it's because you're not eating enough for what you're asking your body to do. Okay. So, we want to oftentimes consider the entire landscape of what is going on when we're deciding and teasing out these things and we have questions. Um, I really love working with the company, and they are one of our sponsors for this podcast, My Fertility Cloud. I've really enjoyed my conversations with Dr. Gary over time. And I have seen him, and because he trains the colleagues that work there, other colleagues that have worked with some of my clients, do really creative things with letrozole and Clomid. And you can get all these medications at home, and they can help coordinate getting HSG and other things locally for you. So you can still work with one of these doctors that we've vetted, especially if you're not really considering doing IUI or IVF. It might be a really great option to consider working with somebody like this in conjunction with your OB. They're also super hip to like, yeah, let's throw in some progesterone support. It's not going to hurt you. And if it gives you, at the very least, peace of mind, why not do it? Okay. So those are options available to you. If you're already working with a fertility clinic and you want a second opinion, I also love to use this service for second opinions, because they can often come alongside and give you some peace of mind that it does sound like a good course of treatment. Or maybe you want to consider this and bring this option to your doctor and see how they feel about that. So I hope that this episode, I know I kind of like spit through them at you, and it's not as conversational as some of our other episodes where Sophia and I are together, but I hope that it was helpful. I want you to hear that if you have to use some of these medications, it doesn't mean that you've failed, doesn't mean that your body's broken. It doesn't mean that anybody is any better or any worse than you. Okay. Sometimes you need medicine for your body to do a normal function. Nobody's telling your husband or your best friend to not take allergy medicine in allergy season. They can't function without it, right? You wouldn't tell them not to take it because they need that to just breathe. You may need support to ovulate. I think that it's always wonderful if we have the time and desire to consider holistic options as well that are more in the diet, lifestyle, supplement, botanicals, herbs, and just food, macronutrient adjustments. I think that that is great. I think that that should be a first line option for anyone with PCOS. But if you need more support, hear me now. It's not wrong to consider these options. And I hope that this episode has given you enough information to kind of understand how they work and to help direct conversations with your providers, help you advocate for yourself, and help you feel more informed in this journey. As always, the best way to support us and say thank you for these free episodes is to like, follow, share, send this to a friend of yours that has PCOS, send it to a friend of yours that's trying to conceive that might want some education and community along the way. Another way that you can support us is if you're going to consider booking with somebody like My Fertility Cloud, use the link in our comments. Not only are you going to get a discount, but it tells Fertility Cloud people are hearing about them from us. If you're going to buy Fond bone broth, maybe consider buying it online instead of at Whole Foods or Amazon or grocery, wherever you buy your groceries, Sprouts, because it shows them our education about them is working. Okay. We are also so blessed to be sponsored again and again and again by Fullwell, which is our favorite prenatal. And if you are buying your prenatals, consider clicking this link down below and purchasing your prenatal or your egg quality support or their new collagen peptides product. They also have new at-home fertility testing for vitamin D and TSH and a few other things. I would consider purchasing through our link because that's another way that you can support us in this podcast. We brought on sponsors to help us continue this effort. And we also only bring on sponsors that we use their products ourselves, totally believe in, and want to shout from the mountaintop how wonderful they are. Quality, care, all the way through. And that's another way that you can really support us. Hey, friends, we're taking a break from our episode to talk about one of our sponsors. And this sponsor is the PCOS app. Did you know that I made an app all about PCOS? Well, I did, and you can find so many resources in it. We have slowly moved all the resources from my PCOS Hormone Academy course over into the PCOS app, and that talks about all things PCOS topically. Like if you have acne, you can go look at the skin and acne modules and see what does Western medicine offer? Why does this impact PCOS? What can we do about it? What are natural remedies? What are nutritional remedies? We talk about hair loss and hirsutism all through that lens where we go through what is it? Why is it impacted by PCOS? Or why do we need to pay more attention to this particular thing? And what can we do about it? And we provide a vast resource to help you both advocate for yourself at the doctor's office and treat yourself at home naturally. Now, the exciting thing that I want to share with you is starting in January 2025, we're starting to migrate all of the content that I have published so far on fertility into this app. I used to sell a course for $700 all about how to get pregnant with PCOS, and that is all getting moved into the app between January and March. So you can take the course as if you enrolled in the whole thing for $10 per month. So head to your app store, whether you're on a Google Android device or an Apple device. If you type in PCOS app, you just look for that really pretty lavender flower. You'll find it. Download it and join us because you're going to get weekly recipes and all the fertility focused PCOS content that you need. It will start being uploaded under the Academy tab. So stay tuned for that. And let's get back to our episode. Today, I'm going to celebrate a yeah girl. I'm alone, but I'm going to do it. We have had the worst stomach flu the entire week. It's Sunday. It started last Sunday with my daughter, then me, then my husband, then my other daughter, and my mom. I am praising the Lord above that my 3-year-old son and my 74-year-old father, who has esophageal cancer, who just finished chemo and radiation, have not gotten this tummy bug. It is like the biggest yeah girl. Also, last night I got my first full night of sleep in 2 weeks because of this and a few other things. So yeah girl to me, yeah girl. I hope you're having a great week and I can't wait to see you next week with our next episode. Bye.